Good morning, my name is Genevieve and I'm going to be doing a newborn assessment on Kevin here. I've already gathered my supplies. I've got my stethoscope, my pen light, my gloves, and a measuring tape here. I'm going to perform hand hygiene and provide privacy. Kevin was born just around 18 hours ago via vaginal birth with no complications. I'm gonna get him unwrapped here so we can look at his general appearance. He seems to be a healthy pink color. His posture is relaxed, but that's okay because he's been sleeping all day. His proportion is normal. His head is a little bit on the large side, but that's normal for newborns. For movement, I'm going to touch him on both arms and see if he responds, and he does, equally on both sides. For his skin, I'm not seeing any bruising or anything abnormal. I'm now going to get some measurements on Kevin. I'm going to apply my gloves. We're going to start with his weight, which is 3,200 grams, and the normal range is 2,500 to 4,000 grams. His length, to get that, we're going to stretch out his legs and measure him from the bottom of his foot to the top of his head. He is measuring at 52 centimeters, which is great because our range is 48 to 53 centimeters. I'm now going to lift his head slightly to measure his head circumference right at the eyebrows. He is 35 centimeters, which is great because our normal range is 32 to 36 centimeters. His chest circumference, we're going to measure that right at the nipple line, and he is measuring at 32 centimeters. Our normal range is 30.5 to 33 centimeters for chest circumference. So all of his measurements are looking great. We're now going to move on to his respiratory. Normal respirations for a newborn are about 30 to 60 breaths per minute, which is irregular respiratory rate, but it's normal for babies. We are going to count his respirations while also we're going to be looking and feeling his respirations. I'm going to count these for 1 minute. All right, and his respiratory rate is 48 beats per minute. It is important to know the signs of respiratory distress, which include retractions, which are sunken in intercostal spaces when breathing, circumoral cyanosis, nasal flaring, elevated respirations, grunting, or seesaw breathing, which is asymmetrical chest movement when breathing. To auscultate his breath sounds, I'm going to use the bell of my stethoscope because I don't have a pediatric stethoscope. I'm now going to start listening to his breath sounds. All right. If he were born by C-section, he would have more secretions and not as clear of lung sounds because the vaginal canal did not push all of the secretions out for baby. But he has clear breath sounds because he was born via vaginal birth. Now we're going to move on to his cardiac assessment. For his heart rate, we are going to listen to his apical pulse. For a full minute, we are going to listen at the third or fourth intercostal space, more lateral than midclavicular on the left side. All right, and I got 145 beats per minute, which is great because our normal range is 120 to 160 beats per minute. I'm now going to feel his brachial pulses. The pulses are equal bilaterally with a normal rhythm with +2 strength. I'm now going to remove Kevin's diaper and check his femoral pulses, which are right at the groin. These are also equal bilaterally with a normal rhythm and +2 strength. Okay. Our normal blood pressure for a newborn would be a systolic of 65 to 95 and a diastolic of 30 to 60. However, we are not going to get a BP on Kevin because we only get a blood pressure on newborns if there's something that is suggesting a cardiac issue. Now we are going to be moving on to Kevin's head. We are going to check his suture lines and make sure that they are not overlapping. They are not, and they are well approximated. We are also looking for 2 fontanelles here on Kevin. We have the anterior fontanelle, which is diamond shaped and larger than the posterior fontanelle, which is triangular. Neither of his fontanelles are sunken in, which would indicate dehydration, and neither are bulging, which indicate excess fluid and increased intracranial pressure. Kevin does not have a caput saccadium, which is a cone-shaped head due to a vaginal birth. It resolves quickly, which I think has already resolved, and causes swelling across the suture lines. Cephalohematoma is bleeding in between parietal skull and scalp, one or both sides. Babies are not born with this. It will occur 24 to 48 hours after birth, and it will take weeks to months to resolve. Now I'm going to be assessing baby Kevin's eyes. Kevin's eyes are a slate gray color with no yellow, indicating jaundice, so he doesn't have any jaundice. His pupils are round. I'm going to check for reactivity to light. His pupils are reactive to light. We cannot test for accommodation because baby cannot see that far yet. Now we're going to move on to Kevin's ears. We are going to check that the pinna, or the top of the ear, is aligning with the outer corner of the eye, which it is. So everything's looking good there. We do not see any preauricular skin tags along the ear. These would indicate a renal malformation. We are now going to check the patency of Kevin's nostrils. So I'm going to close one nostril and feel for airflow from the other. Okay, I'm getting good airflow on this side and on this side. I'm also going to be covering the mouth while I'm doing this. And looks like we're getting good airflow from both nostrils. Now we are going to assess the baby's mouth. I'm going to put my gloved pinky in his mouth, and he is sucking, so that is, he has a present rooting reflex. His mouth is symmetrical. We don't have any white areas around the mouth, but if we did, these would be Epstein pearls, which are normal. We don't have any cyanosis present around the mouth, so that means that he's getting good oxygen perfusion. If he did have circumoral cyanosis when crying, that may indicate a congenital heart issue, but we don't have anything like that right now. We are now going to move on to assessing Kevin's neck. He has a short neck with thick skin folds, no webbing, and no fat pads. We're going to move baby's head from side to side to check for resistance. We don't have any resistance when moving baby's head from side to side. So now we're going to move on to the chest and clavicle. A broken clavicle is common during a vaginal birth, but I'm going to feel along Kevin's clavicle, and I do not feel any lumps. So a lump would indicate a possible fracture, but looks like Kevin does not have a fracture. His chest is a normal shape, and he has 2 nipples that are symmetrical. Now we are going to move on to Kevin's abdomen. We are going to auscultate his bowel sounds before palpating. I'm going to start in the right lower quadrant and go on from there. And Kevin's abdomen is soft, round, and symmetrical. Sometimes in newborns you will not hear bowel sounds if they were just born, but Kevin does have some active bowel sounds. We are now going to check baby Kevin's umbilical cord. We have 2 arteries and 1 vein, and it is bluish white in color because he is only 18 hours old. The cord will usually be bluish in color when the baby is fresh and darken with time. There is no bulge, but if there was, that could indicate an umbilical hernia. Now we're going to move on to Kevin's extremities. We are going to start by testing his Moro reflex. We are going to lift the baby up and then put them back down, and this startles him, and then he curls back up, so that is a positive Moro reflex. We are now going to check for hip dysplasia by moving the hips out and bring them back in at the same time. And we're feeling for any dislodgement or clicks, which I do not feel. We are now going to check for a simian crease on Kevin.
Hello, can I use this? Is it cold in here?
He has multiple creases. And we're also checking to see if he has any extra digits, which he does not. We are now going to check his Babinski reflex by running our finger up his foot, and we're going to have his great toe is going to stand up and the rest are going to flare out. We are going to check his plantar grasp by seeing if he will wrap his toes around my finger, which he does. I'm also going to do this on his hands, and he does the same thing. All right, now we're going to move on to Kevin's back. I'm going to pick him up and support his head. His back is straight and flat. He does not have a tuft of hair indicating spina bifida or any dimpling which would indicate a pyonidal cyst. His buttock folds are symmetrical and legs are equal in length, which is perfect. All right, we're gonna put him back down. Now we are going to assess little Kevin's genitals. In males, it's very important to palpate the testes to make sure that we feel both have descended, and we are observing penis for epispadias and hypospadias. We are also going to observe the anus for any fissures, and we don't have any, so that is good. If Kevin were a female, there may be some swelling of the labia, vernix may be present, and there may be a small bit of vaginal discharge or bleeding due to maternal hormones. All right. I am going to now wrap Kevin back up and return him to his mom. All right. I'm going to remove my gloves, perform hand hygiene. Mom knows that baby is here with her, and I have the call bell within reach for her. Thank you.